I would like to discuss the impact of the types of insulin on hypo and hyperglycemia during Ramadan fasting. Before I begin, I submit to you my disclosures. And in the time allocated, what I would like to do is discuss some of the risk factors that are associated with hypo and hyperglycemia during Ramadan fasting. I will then review some of the insulin studies that have been done, particularly in patients with type 2 diabetes during Ramadan fasting. And more importantly, I would like to highlight the results of the Dar Global Survey that was conducted in 2020 on the use of insulin and its effects during Ramadan. So in terms of the epidemiology, we're very fortunate in that we've had 4 landmark diabetes in Ramadan trials. We've had the EpiDR 2 decades ago, and more recently, we've had the Dar Global Survey, which I'm going to elaborate on a little bit later on. These were multinational studies that involved quite a number of patients, and they gave us great insights about the practices of patients with type 2 diabetes during Ramadan fasting. What is unanimous about all these trials is the fact that the number of days that were fasted is almost the same. So whether it was 2 decades ago or whether it was just 2 years ago, we can see that the mean number of days fasted was around 27. Now, as physicians looking after patients with diabetes, be it during Ramadan or outside Ramadan, what we would like to do is always strike this balance between hyperglycemia and hypoglycemia. And so when we look at the risk factors or the factors that are associated with an increased risk for hypoglycemia, we know that advanced age with frailty is one of them. The presence of chronic kidney disease, especially in the later stages, 4 to 5, or patients that are on end-stage renal disease on dialysis are more likely to have hypoglycemia. If the individual has hypoglycemia unawareness, poor glycemic control, or even tight glycemic control, the presence of any acute illness, and the therapy, so insulin and insulin secretagogues, also may increase the risk for hypoglycemia. So this we know in terms of the treatment regimen that the risk or the incidence rate for hypoglycemia is much higher, as was shown by Dunkley, in those patients that are on insulin and those on insulin secretagogues as well. But what about the context of Ramadan? We see the same thing. This is data from the CREED and the Dar 2 study, type 2 study, where again, you can see that the proportion of hypoglycemic events was a lot higher in those patients that were either on insulin alone or with insulin and oral hypoglycemic agents. Now, this is an interesting survey that looked at the baseline factors that may actually predict a hypoglycemic episode during Ramadan. And what is interesting is that these factors listed here were not significantly predictive of a hypoglycemic event. The only thing that was really significant was whether the patient had an episode of hypoglycemia before Ramadan. So if you look at the hemoglobin A1C before Ramadan, the use of sulfonylureas, age, gender, the level of physical activity, the geographical region, that didn't act as a predictive marker for the development of hypoglycemia during Ramadan. And interestingly, neither did treatment with insulin. So let's look at some of the earlier studies with regards to the use of insulin during Ramadan. And these are the ones that were done between 2000 and 2015. We can see that most of them are open-labeled observational studies. And therefore, when we make the conclusions or draw conclusions from these studies, we do that with a bit of caution. But what we could say is that the rapid-acting insulin analogs, such as insulin lispro, did show to have lower rates of hypoglycemia than the human insulins. On the other hand, longer-acting insulins, such as glargine, were found to be safe as monotherapy or in combination with the insulin secretagogues. And then the studies that compared pre-mixed analog insulins with the human insulins showed that a pre-mixed insulin analog provided a better average daily glucose control, especially at around iftar time, without any increased risk of hypoglycemia. But then again, I say, because these were observational and open-label studies, the conclusions that we can draw from them are quite cautious. So Moving on from then, we have this elegant literature review that was conducted by Al-Aboud and colleagues, and he looked at 16 studies, and what they found was that all the studies except one found that there was actually improvement or no change in glycemic parameters in those patients that were on insulin. The incidence of major complications was quite negligible. Minor hypoglycemia was reported in some studies, but it didn't adversely affect fasting. Postprandial hyperglycemia was a concern in some of the studies, but the incidence of severe hyperglycemia and diabetic ketoacidosis were quite trivial. And therefore, the conclusion from this literature review is that Ramadan fasting is feasible for most patients with type 2 diabetes on insulin who wish to fast. So then, does the type of care really matter? And this was a question that our colleagues in Dubai Hospital here in Dubai Health Authority wanted to answer. And they looked at the impact of optimum diabetes care on the safety of fasting in Ramadan in adult patients with type 2 diabetes, was specifically on insulin therapy. And in fact, what they were able to show that with optimum therapy, we are able to, in fact, reduce the number of hypoglycemic events during Ramadan when compared to outside of Ramadan. And then interestingly enough, when they looked at the comparison between basal and intensive insulin therapy with regards to hypoglycemic events, what we can see is that when the patients that were on basal insulin therapy had numerically lower risk for hypoglycemia in general, and the hypoglycemia tended to occur between midday and just before iftar. So in this study, they showed that the basal insulin-treated patients had a slightly lower risk for hypoglycemia than those that were on a basal bolus regimen. So then let's look at whether the type of insulin really matters. And this was an elegant study that was used to compare the difference between insulin degludec with insulin aspart combination, the IDEC-ASP, as opposed to biphasic insulin aspart 30. And this was a randomized trial that was conducted in various countries, Algeria, Lebanon, Malaysia, and South Africa. So it was quite well represented in terms of the geographical distribution. And what we find from that study is that there was no significant difference in terms of the hemoglobin A1C or the total amount of insulin that the patients required between either IDEC-ASP or the bi-ASP 30. But what was clearly significant was the lower risk of both confirmed hypoglycemia and nocturnal confirmed hypoglycemia, which was lower in the patients that were on the IDEC-ASP as opposed to bi-ASP 30. The second randomized trial was the Orion study, and this was with insulin glargine 300. And again, they wanted to look at the percentage of people with more than one episode of severe or documented hypoglycemia. And what was seen again, the countries that participated here now were the MENA region, India and Pakistan, and there was a few patients that also included from Canada. So what did we find? That the glycemic control with those patients that were on the glargine 300 improved between the pre and post Ramadan period. So we can see here all the glycemic parameters, the hemoglobin A1C, the fasting plasma glucose were much better post Ramadan for those patients that were on the glargine 300. And this did not come at the cost of increased hypoglycemia. In fact, they saw that the hypoglycemia occurred quite infrequently in both the groups, but much less so in those patients that were on glargine 300. Then we had the DAR 2020 global survey, which really looked at the Ramadan fasting during the COVID pandemic. And in that survey, we were able to collect a lot of data. Some of it has already been published, as shown here. But what I'd like to do now is look at the data specifically on the patients that were on insulin. Now, this was a survey that was conducted in 5 geographical regions. We had the Maghreb, represented by the countries with the flags shown on the slide. We had Southeast Asia, We had the Gulf countries, we had the Eastern Mediterranean, about 12 countries in there, and the Indian subcontinent. And so what I'm now going to do is show you some of the data from this survey. This is unpublished data, but we have a lot of insights from the survey. So first of all, if we look at the insulin types, according to the regions, whether they were, which regions used more of the basal analogs, NPH, the basal bolus analogs, or the human basal bolus regimens. And we can see there from the data that there was a predominant use of basal analogs, particularly in the Gulf region, whereas NPH and the human basal bolus regimen was more commonly used in the Indian subcontinent and Southeast Asia. Then if we look at the baseline characteristics of the patients, the average age was around 58 years. These were patients that were on insulin therapy, so it's not surprising to find that they had a duration of diabetes greater than 10, and the hemoglobin A1C ranged from 8.7 to 9.4%. Clearly, they were uncontrolled and or suboptimally controlled. Then when we look at the comorbidities and some of the complications that they had, what we find is 55% of them had hypertension, 45% had dyslipidemia. Microvascular complications were much more common than the macrovascular complications. And of the microvascular complications, diabetic neuropathy was the one that was most frequently reported. What about the number of days fasted? Was there any difference between the type of insulin that they were on? And as we can see here, just as I showed you in the global survey, 26 to 27, and there was no difference whether the person was on a basal analog, whether they were on a basal bolus regimen or NPH. Then we look at the percentage of, or the proportion rather, of patients who broke their fast because of diabetes-related illness, either hypo or hyperglycemia. And what we see quite interesting numerically is that those patients that were on NPH were less likely to break their fast because of diabetes-related illness. But we need to look and see whether this was statistically significant. And perhaps when we have the next conference next year, we will have more insight as to some of the reasons why this might be so. And then when we look at the daytime hypos, almost similar, but again, as you can see numerically, the daytime hypos was much less in those patients that were on NPH as opposed to the basal analogs. And then when we looked at the type of insulin and the timing of the hypo, what is interesting to note is that the hypos occur more frequently between 3 p.m. and 7 p.m., and this is not a surprise, irrespective of what the insulin type was. Now, how many of those patients actually broke their fast because of hypoglycemia? We are not surprised to find that a higher proportion were those that were on the basal bolus regimen. And again, here, the ones that were on the analogs, very similar to the ones that are on the human, 70 versus 69%, but much more than the ones that were on basal therapy. Very similar to the study that was reported by colleagues in Dubai Hospital when they looked at the optimum care and the effect on fasting. Then we also wanted to understand of those that broke their fast, what proportion actually needed to attend the emergency department, the ER room, and what proportion of those were admitted due to hypoglycemia. Reassuringly, we see that there are very small numbers that were actually required to be admitted to hospital as a result of hypoglycemia. So this is quite reassuring that patients can fast during Ramadan without having the risk for admissions because of hypoglycemia. Then let me now focus on hyperglycemia. And from the EPIDR study, we know that there was an increase of about 5-fold of DKA in patients with type 2 diabetes, and there was a 3-fold increase in those patients with type 1 diabetes. We conducted a couple of years ago a prospective study that actually looked at the incidence of DKA during Ramadan and the month after Ramadan. And in fact, we didn't see any difference in the incidence of DKA. And this has been reported by other investigators in the region as well. So the risk for diabetic ketoacidosis really isn't a huge problem in our patients with type 2 diabetes that are fasting during Ramadan. Then if we look at the daytime hyperglycemia, here is the patients who had glucose readings of above 300 milligrams per deciliter. For some reason, we also find that more patients that were on the basal bolus analog regimens tended to have more hyperglycemia, and they were the ones also then that broke their fast more commonly as compared to the other patient groups. Then when we look at the admissions for hyperglycemia or the attendances to the emergency room, here again, we can see that numerically, the patients that were on the basal bolus analogs tended to have higher need for attending the emergency, and maybe this is because they have greater access, say, than to the patients that were on MPH. And the admissions due to hyperglycemia, on the other hand, we find that numerically there's more of those on MPH as compared to those on the basal analog. So what are the key takeaways from the Dar Global Survey? We know that many patients with type 2 diabetes on insulin therapy can safely fast during Ramadan. Most of the patients with type 2 diabetes, as I showed you, had poor glycemic control, which contributed to the higher rates of hyperglycemia during Ramadan. So this is something that we need to address in the pre-Ramadan period, counseling our patients and making sure that they're going into Ramadan optimally controlled. Then optimization of therapy and the insulin dose titration is really important in order to mitigate both hypo and hyperglycemia, because the two are equally important. We know that hypoglycemic episodes occur more frequently between 3 and 7 p.m., irrespective of the type of insulin that is used. And in general, the severity of hypoglycemia is really, really low without the need for hospitalization. The other thing that we noted was there was no significant difference in the ER attendances or admissions for hypoglycemia or hyperglycemia between the insulin analogs and the human insulins. So to summarize then, we know of the proven metabolic benefits of Ramadan fasting, both in healthy individuals and in people with diabetes. But we emphasize that a pre-Ramadan risk stratification is really important for all patients with diabetes to guide and support them so that they can have an informed decision-making. The use of insulins ranging from rapid-acting to long-acting analogs, ultra-long-acting analogs, and the premix have been found to be both safe and efficacious during Ramadan. And the doses and timing should be adjusted in the pre-Ramadan assessment, and patients should be supported during Ramadan with dose titration in order to optimize the glycemic control and thus improve on their fasting experience. And with that, I'd like to stop there. Thank you for your attention and wish everybody a blessed Ramadan.